Okay, great, thank you. So I've got a case presentation today. We're going to change the topic slightly from NSTEMI to acute arrhythmias. And I'd like to share this particular case, I'd like to call the domino effect. So I have no conflicts of interest or disclosures to declare. So there's a 25-year-old patient is admitted to their local district general hospital. They've been very breathless and they've been complaining of palpitations for the past week. In particular, they've been feeling unwell and having intermittent chest pain. They're previously fit and well. They don't have any they don't take any regular medications, and they've got no known drug allergies. And they do admit to having used cocaine and cannabis in the past, but nothing in the past month. So the patient walked into ED. They went to triage, and their initial observations were completely normal, as you can see. Their apyrexial heart rate is 70, blood pressure 120/75, SATs 99% on air. While they were waiting in the waiting room to see a doctor, they suddenly felt very unwell, and they had palpitations. And when they checked their pulse rate, they found that it was 190. So the patient was then taken straight across to resus, and a 12-lead ECG was performed. Here is the 12-lead ECG. So I'd like you to take a few moments to have a look at the ECG, and we will be setting a poll. I think, have you got the poll set up, Abdalla? So the question is, what is the rhythm? Is it sinus tachycardia? Is it AFib, atrial flutter, atrial tachycardia? Or is it a re-entry SVT? Okay, so I'm going to stop that. Okay, let's move on. The next question is, what's the next step in managing this patient? Would you give adenosine, beta blocker, a calcium channel blocker, amiodarone, or would you perform a DC cardioversion?
Sorry, Ahmed, I don't think we have got this question on the poll at this time.
Oh, okay. No, not a problem. Okay, so we'll end that polling. Okay. Let's find out what happened. So the ECG, I agree, demonstrates atrial fibrillation. And you can see that there are irregular R intervals. And if you look for P waves, you won't find them. Or if there are some atrial activity there, it's abnormal. And that's the hallmark of atrial fibrillation. Remember, V1 is usually often the best lead to look for P waves. And if you look at between the first beat and the second beat, there's a slight slowing of the rate, which allows you to then, in this area here, you're able to look to see if there are any P waves. There is also evidence of LVH. And if you look at V1 and V6, and if you add the S wave and the R wave, the S wave in V1 and the R wave in V6, you can see that it's over the threshold of 35 millimeters for LVH voltage criteria. Okay, there's also T wave inversion in the inferior leads and also in the anterolateral leads. And this could be rate-related ischemia, or it could also represent LVH with strain pattern. So the patient was given verapamil, IV. Subsequently, they developed hypotension and their blood pressure dropped to 70 systolic, and they were given IV fluids, bolus, as well as magnesium and potassium. Then they developed type 1 respiratory failure, and a chest x-ray confirmed pulmonary edema. So the IV fluids were stopped and the patient was given IV furosemide, and they were also referred to the intensive care. This was all in the emergency department in A&E Resus. This is the ECG, which clearly demonstrates that atrial fibrillation. You can see the ventricular rate has slowed down. So what is the next step? Would you give this patient adenosine, beta blocker, digoxin, amiodarone, or a DC cardioversion? Do we have a poll for this, Dr. Abdalla?
No, I'm afraid we don't have poll for this one, Ahmed. Sorry.
Okay, no problem. So I'll give you a few moments just to have a think about what your next step is for this patient. So the patient was given IV amiodarone. Their troponins came back as 29 and 27, so no dynamic changes. And the intensivist tried to arrange an echocardiogram out of hours. This patient was in the department out of hours, unfortunately, and it was unavailable. Remember, the patient was in a district general hospital. Now, intensivists, because of the hypotension, they were considering to perform a DC cardioversion. But then, this happened. There was a change in rhythm. So I'll give you a few moments to have a look at the ECG. Okay. So the question is, what is the rhythm of this ECG? Is this sinus tachycardia? Is this atrial fibrillation? Is it atrial flutter? Is it an atrial tachycardia? Or is it a re-entry SVT? So for example, AVNRT or AVRT. So I don't think we have the polling available, is that right? Okay. So the patient then went on to have a DC cardioversion. And in fact, they were given 2 shocks at 150 joules, but there was no effect. And here is the rhythm strip before and after the DC cardioversion. The top is before and below is after. So what happened then? So the patient was then started on dobutamine infusion. They were given regular IV furosemide, and they required CPAP for respiratory support. And an echocardiogram was arranged the following day in hours. And here is the echocardiogram for this patient. And this is a parasternal axis view demonstrating that the left ventricular internal diameter was significantly dilated, 8.9 centimeters, or 8.8 centimeters. The patient also had a degree of mitral regurgitation, was reported as moderate. And yes, they had severely dilated left ventricle with severely globally impaired systolic function, and with a left ventricular ejection fraction of 20 to 25%. All chambers were dilated. The right ventricle was also impaired in terms of systolic function, and they had moderate mitral regurgitation. I did not show all the views, but there wasn't any evidence of a left ventricular thrombus, although I do agree on that particular image there was a suggestion. The patient was then referred to the tertiary center for transplant workup. In fact, they were referred to a tertiary center and they were in fact referred to a transplant center. And this is the ECG on arrival to the tertiary center. So I'd just like you to take a few moments to have a look at the ECG. Does anybody want to comment on the ECG? That's fine. We'll just move on. So we agree that it is sinus rhythm, but we'll talk about it in a moment. So the sinus rhythm, but did anyone spot the QTC interval? So the computer readout showed that the heart rate was 106 beats per minute, so it's slightly sinus tachy, and the QTC interval, right, the computer calculated QTC interval was 509 milliseconds, which is significantly prolonged. So just have a look at that again, and you can see the QT prolongation there, which is something very important to look at. The patient went on to have a right heart cath. And as you can see, there was evidence of pulmonary hypertension. The mean PA pressure was 34 millimeters of mercury, and it appeared to be left-sided, as demonstrated by the pulmonary capillary wedge pressure was elevated at 25. The cardiac output was reduced for somebody of that age. 3.5 liters per minute, reduced cardiac index, and the pulmonary vascular resistance was elevated at 3 Woods, which is elevated, although not drastically elevated. So, what happened in this case? There are a number of lessons that can be potentially learned from this case. Firstly, I'm suggesting here some alternative management for the patient when they were in A&E. Perhaps they could have received metoprolol IV, for example, 5 milligrams IV, and of course you can give that to most patients. Maximum, I would say, is 10 to 15 milligrams in one sitting. And I tend to also give oral bisoprolol, mainly because I know that the effect of bisoprolol will be longer lasting, and the metoprolol is more shorter acting. You can give 2.5 milligrams and uptitrate. And when I give metoprolol IV, I tend to give 1 milligram. I check the blood pressure beforehand, give 1 milligram, recheck the blood pressure, and then give the 5 milligrams and checking the blood pressure response. You could also consider giving an oral loading dose of digoxin, 500 micrograms up front, and then with a view to a further 500 micrograms 6 hours later, if they still remain in atrial fibrillation with a rapid ventricular rate. Anticoagulation. So you may want to start initially with treatment dose, for example, enoxaparin, and then consider a DOAC later on, just in case the patient may require interventions. It's important to check the electrolytes, renal function, thyroid function, troponins, and also then to arrange an echocardiogram once the AF is rate controlled. The patient if they have severe LVSD, such as in this case, you would start them on heart failure treatment, so ACE inhibitors, beta blockers, plerixone as an inpatient, and then Entresto as an outpatient, or for example. And you can discharge the patient with an outpatient DC cardioversion 6 weeks down the line. And in the meantime, you can arrange for the patient to have a cardiac MRI as an outpatient. So verapamil. Verapamil is structural heart disease first, as this case demonstrates. In fact, verapamil can be very effective for rate control in atrial fibrillation when combined with digoxin, and particularly is of use in patients who have a true contraindication to beta blockers, so patients who have severe asthma. You would not use verapamil in such a patient who has such significant structural heart disease. Now, were there any clues for this patient who had an undiagnosed dilated cardiomyopathy? Remember, the patient walked into the ED. So perhaps you can use clinical clues. So for example, when you're assessing patients and you feel for the apex beat, is it displaced? Is it significantly displaced? That might give you a clue that the patient may have a cardiomyopathy. Can you hear a mitral regurgitation murmur? Is it significant? Again, these are all clues to let you know that there may be underlying structural heart disease. Similarly, you may find cardiomegaly. For example, on the chest x-rays, you can see here that this is significant cardiomegaly for a patient in their 20s. Increasingly, a lot of patients who come acutely will have some CT cross-sectional imaging. So you may be able to look at the CT scan and look at the cardiac chambers and look to see if there's evidence of any dilated cardiac chambers, left ventricle or dilated right ventricle. And of course, bedside echocardiogram is very useful in such patients too, if you have a suspicion. Are there any learning points regarding fluid resuscitation? So remember, the patient was given verapamil, dropped their blood pressure, became hypotensive, and so they were given fluid bolus, which is, fluid bolus is not an unreasonable thing to give patients who are hypotensive. But perhaps you could check the JVP first and see if the JVP is elevated, then there's less value in giving IV fluids. Remember, the JVP is a marker of right atrial pressure and your cardiac filling pressures, right-sided filling pressures. And when you give IV fluids, you are essentially trying to increase the amount of the filling pressure within the right side of the heart. A bedside echocardiogram is also very useful, particularly, and I use it quite a lot for IVC assessment. If you look on the image on the right here, you can see that this is a dilated IVC, and there isn't very much collapsing or any respiratory collapse on deep inspiration. Again, this is suggestive of high right atrial pressure. And if you see this on your echo, then there's less value in giving IV fluids in such patients. So what can we learn about the cardioversion that was performed? If you remember, the patient had a cardioversion at 150 joules. They received 2 shocks, and there was no change in the rhythm. So yes, DC cardioversion sometimes does have to be performed in patients with atrial fibrillation, particularly if there's hemodynamic instability. So you may need to perform an emergency DC cardioversion. It's also very important to think about the anticoagulation plan in such patients. And sometimes we would need to do a TOE guided cardioversion. Now, the reason for this is because of the stroke risk associated with atrial fibrillation. You don't know how long the patient has had atrial fibrillation for, and you don't know how long their episodes of atrial fibrillation are. I mean, in this case, the patient had paroxysmal atrial fibrillation, we assume, but of course he did not have an ECG initially when he was feeling well. So often one of the misconceptions people have is that there is no real difference in stroke risk if you give a patient, if you cardiovert the patient pharmacologically versus electrically. They think that giving amiodarone, for example, and cardioverting the patient chemically does not really incur a stroke risk, but actually it does. So you have to consider that in patients, even if you give them amiodarone, that if they're at high risk of stroke, they should be on anticoagulation. So remember, with for atrial fibrillation, you have to do a synchronized DC shock. And in cases where it's been unsuccessful, you have to think of a few possibilities. Now, number one, it could be that you have given inadequate energy. So 150 joules may not be adequate in somebody who is very large and has a lot of adipose tissue, for example. You may need to go higher energy, 200 joules. And my general practice is to use the 200 joules the first time. I know certain hospital protocols do vary, but I tend to use 200 joules. It may well be that actually the arrhythmia is incessant. So what happens is you cardiovert the patient, it terminates their rhythm, and they have maybe a beat or two or few of sinus beats, and then the arrhythmia returns. So in that situation, if that was to occur, then that tells you that really there's little value in trying to repeat the cardioversion. So if you do the first shock, you see that you terminate the arrhythmia, and the patient has even one sinus beat, but then the arrhythmia returns. There's no value in performing second shock. And what you need to do is look into the reason why is this arrhythmia incessant. Is there something driving it? For example, infection, or electrolyte abnormalities, or thyrotoxicosis, for example. And another reason for the lack of success is that the patient is in a sinus rhythm or sinus tachycardia. And that's the reason why, despite giving them a shock, there's no change, because they're in a sinus rhythm anyway. The other thing to consider is the position of your pads. And I generally prefer to use the AP position. If you look at the diagram, the CT on the right, you can see that the energy is being delivered across the heart, and therefore the chances of success is a lot higher using the AP position. In some cases, we have to consider an internal cardioversion, particularly if patients have got very large patients, a lot of adipose tissue. You may want to consider an internal cardioversion. Okay. And then, were there any lessons to be learned about adenosine? So yes, adenosine I think is a useful medication, and I find it very helpful when I'm in doubt of the rhythm. Remember to avoid using adenosine in patients who have asthma, and I think it's very important to record the 12-lead ECG and a 12-lead rhythm ECG during adenosine. It's important to use a large central cannula, antecubital fossa, and remember to give a very rapid bolus of adenosine and a rapid flush as well. Now, in terms of the doses, in a lot of textbooks, they'll say 6, 12, 12, for example, 6 milligrams, 12 milligrams. But I tend to use 12 milligrams as a starting point, and then I may increase it to 18 milligrams. It's always very important to warn the patient about the symptoms so that they don't panic. Now, if the adenosine has no effect on the rhythm, then there's a few things that I like to check. First of all, I check with the patient. Did you have any symptoms? Did you feel unwell? Did you feel tightness? Did you feel flushing sensation? If the patient doesn't have any symptoms of adenosine, then probably they didn't receive an adequate dose. Or it could be that there's a problem with the cannula site. So I would check the cannula, make sure it flushes and that it hasn't tissued, and that it is really a large cannula in an adequate position. If not, simply put a large cannula in the right position and repeat. And if the patient genuinely doesn't have any symptoms, and I've checked the cannula and I'm happy that they've definitely administered the drug, then I would give them a higher dose in that situation. And sometimes some patients do need to have higher doses. And as you can see here, this is an example of a patient that was in a narrow complex tachycardia that was regular. And when they were given adenosine, it caused temporary AV block, enough for you to unmask the underlying flutter. You can see this atrial flutter waves, the flutter waves very nicely in this case. Now, when I mentioned about a 12-lead rhythm ECG, whenever I ask A&E colleagues to try to do this for me, they find it very unusual. They don't quite understand what I mean. So what this is an actual rhythm strip of with 12 leads continuously printing. And on the left-hand side, you can see that this patient was in a narrow complex tachycardia, that was regular. And when they were given adenosine, you can clearly see that there's termination of that arrhythmia, and then a few ectopics, and then there's, on the right-hand side, you can see that the patient has a nice sort of sinus rhythm. And the reason that I like to use 12-lead ECGs is because I can look at the P waves, and I can look to see which, so the P waves may be more clearer in certain leads rather than other leads. So that's why I tend to prefer to use a 12-lead rhythm strip. That way I can have a good look at all the leads and identify the P waves and all the flutter waves, etc. And then in terms of antiarrhythmic drugs, so remember the patient was on amiodarone. So remember to think about QTC prolongation in patients who are on amiodarone. And if you do see such a patient, remember to manually check the QTC interval is genuinely prolonged in the methods that I've described earlier. Especially if you see that the computer is telling you that there's QTC prolongation. If you do notice QTC prolongation, then it's very important that you recognize this and avoid prescribing other QT prolonging drugs, because that can just exacerbate the situation and increase the risk of the patient developing torsades and other ventricular arrhythmias and VF, etc. So I'd like to thank you for your time, and that's the end of my case.
Thank you very much, Dr. Ahmed. This was really a good case, and of course, it's raised a lot of learning points.
Point of the case was to highlight this and not to avoid using verapamil without knowing what the echocardiogram shows for the patient. Regarding the QTC and which lead, it's a very good question, and in my practice, I find that the lateral leads are actually better to measure the QT interval. But I know that in some groups they report using some of the chest leads, so from V1 to V3. But you have to choose the lead which clearly shows the onset of the Q. So that's the first thing, and also shows the end of the T wave clearly. So those are so I tend to find that lateral leads are better. So that's lead 1 or EVL.
Thank you.
Thank you, Dr. Ahmed. I think there's a question from Dr. Safa Eltyeb earlier, just to the chat group. She said possible this. I mean, they regard the cause of this patient arrhythmia from the beginning. I think that initially when you started your first slide, she said possibly might be idiopathic or possibly drug-induced.
In terms of the cardiomyopathy, or the?
I think so. Yes, I think cardiomyopathy from the beginning.
Yeah, I mean, it's very interesting. You know, often what we see is that patients can have severely impaired LV function, and we know that atrial fibrillation can, particularly if it's associated with rapid ventricular rate and uncontrolled for long periods of time, it can cause a tachycardia-induced cardiomyopathy, which is usually reversible. So that's on the one hand. On the other hand, you can have a patient who has a dilated cardiomyopathy, and the AF is just secondary to that dilated cardiomyopathy or whatever cardiomyopathy they may have. So what we sometimes find is actually the patients in the middle, where they have both. So they may have a degree of structural heart disease, which is just exacerbated by the AF. So they may have a moderate LVSD, which when they go into AF with rapid ventricular rate, it then becomes severe. And the way that you can tell is by getting them back into normal rhythm for a period of time and reassessing the echo and seeing whether or not the LV function improves. And the second thing is to look to do a cardiac MRI, because a cardiac MRI is the best modality to give you an idea of what is the cause or the etiology of the LV dysfunction. So whether that may be a DCM, an ischemic cardiomyopathy, or a non-ischemic cardiomyopathy.
Actually, if I may comment, thank you for your last comment about the importance of cardiac MRI in further clarifying the cause of this sad-looking left ventricle, which is very dilated, barely whispering. And the two questions I put is, what is the cause of this severe LV dysfunction? Is it a dilated cardiomyopathy? But I remembered you mentioned the patient history. He gets high from time to time and he used drugs. If I remember right, he used cocaine or something. We should not dismiss the fact that there's quite a number out there in the community who are using or abusing drugs, and it has its hit on the left ventricle, both on the short term and on the long term, and that might be the cause of their LV dysfunction. And the atrial fibrillation or any arrhythmia actually could be just a red herring. Actually, I take my hat off to the courage of the intensivist who cardioverted him. I would think thousands of times or before cardioverting someone who I do not know his LV function, I do not know his LA size. I have a good idea about the fact that he goes in and out of episodes of palpitations over the last 2 to 3 weeks. That means the chance of him having an LA/LA appendage / left ventricle thrombus is quite high. So in this one, I really have to take a consent from the next of kin that there is a very good chance this patient might have a stroke. I don't have an access to an immediate echocardiogram, and I have no option but to cardiovert. Otherwise, I wouldn't do that.
Yeah, thank you, Dr. Safa. I think that's excellent points. And for me, the size of the left ventricle, more than 8 centimeters, it makes it some sort of familial DCM, inherited cardiomyopathy, a little bit more likely. But yes, definitely with the history of medications and the history of drug use. The cardioversion, actually, interestingly, so they cardioverted the patient with amiodarone. That actually successfully reverted. And remember, this patient we think has PAF based on his symptoms. But they arranged a cardioversion for what they thought was an atrial flutter, but actually it was a sinus tachycardia. And that was the reason why the cardioversion didn't do anything. It was because the patient was in a sinus tachycardia. So I think in that regards, sometimes using adenosine might be quite helpful, because sometimes sinus tachycardias can look like atrial flutters. I have to be honest, you know, they can certainly look like that, particularly if they've got first degree AV block. But thank you for your comments.
Thank you very much, Dr. Ahmed Adlan.